Hello and welcome to Chapter 17, Special Senses. We are going to look at hearing, taste, smell, and equilibrium today. There's a separate video and PowerPoint for vision, so make sure you watch both of them because they will both be pertinent information. So we're going to start with smell. Smell is also known as olfaction. Olfaction, or that sense of smell, is found within the olfactory epithelium of the nose. That olfactory epithelium is only located in the superior part of the nasal cavity. It covers that inferior surface of that cribriform plate, and it's found along that superior nasal concha. We have olfactory sensory neurons, we have epithelial cells, and basal epithelial cells found within that olfactory epithelium. So let's take a look. So we have our olfactory bulb that contains our olfactory neurons as part of this olfactory tract. These neurons come down into this nasal cavity in here. So these bipolar neurons specifically are coming down and they are picking up different scents from within this nasal cavity, this nasal area. We have these supporting epithelial cells here. We've got olfactory glands providing us with mucus for our nasal cavity. So here you can see some of these olfactory neurons, some of these epithelial cells. You can even see one of these olfactory sensory neurons here and this olfactory gland. Here we can see how everything that comes into our nose is going up into that temporal lobe in our brain. So these olfactory sensory neurons are first order neurons. They are bipolar. They are going through that cribriform plate and they synapse in that olfactory bulb. They have olfactory cilia that are extensions off of those dendrites, and they are non-motile. They do not move. But this is where olfactory transduction does take place. So our olfactory receptors of this olfactory cilia, these proteins, detect inhaled chemicals, or known as odorants. Odorants are these chemicals that are going to bind and stimulate these sensory neurons. These neurons are going to pick up or respond to certain chemical stimulation of a specific smell. Those supporting epithelial cells, columnar epithelium, they make up part of that mucus lining found within the nose. And they're going to provide some support. They supply nourishment and electrical insulation for those specific sensory neurons. They also detoxify chemicals that may come in contact. Those basal epithelial cells, these are those stem cells. So they're going to make new cells for us. So they're going to produce those new olfactory sensory neurons because they only live about 2 months. This is what maintains your sense of smell. This is the only place in the body where neurons will be replaced consistently. Those olfactory glands, they produce the mucus that goes to that surface epithelium, and it dissolves these odorants. We're not able to detect smells unless they are dissolved in this mucus. These olfactory glands have the parasympathetic fibers from the facial, from branches from that facial nerve specifically. Impulses can stimulate the lacrimal glands because that facial nerve also goes to the lacrimal gland, and it can result in tears and a runny nose after inhaling certain substances. If you've ever cut onions, you would know. Olfactory sensory neurons are going to respond to different smells or odorants. So they're going to depolarize this olfactory transduction. So this odorant will bind to this sensory neuron. It's going to go through this second messenger process. It's going to use that G protein to activate the enzyme adenylyl cyclase, which activates that cyclic AMP, cyclic adenosine monophosphate, and use that second messenger that we had talked about in chapter 12. It's going to, through this second messenger process, it's going to cause depolarizing of that olfactory sensory neuron. Again, it has to reach that threshold for this information to be sent off to the sensory or the olfactory cortex. We have about 10 million olfactory receptors in our nose. We can detect about 400, or we have about 400 different functional types of olfactory receptors. So just like our sensory receptors everywhere else, each olfactory sensory neuron can only react to one select group of odorants. And there are 400 different types of olfactory receptors within that olfactory epithelium. So it says only one type of receptor is found in any given olfactory sensory neuron. So here's that second messenger process. This odorant comes in and it's going to bind, which causes this G protein to activate adenylyl cyclase, which activates the cyclic AMP, which causes the action potential to actually occur if the signal is strong enough. So we do have a very low threshold for smells. It only takes a few molecules to detect, to actually be able to smell it. But that adaptation is very quick, meaning you smell something, your brain is going to eventually kind of filter it out, even though that smell may still be there. So those olfactory sensory neurons adapt by about 50% in the first second. But then they start to adapt slower after that. It can take about a minute to completely desensitize from that smell, kind of adapt and filter out that smell so you can focus on something else. So the olfactory pathway. Sorry, I wanted a picture. There wasn't one. Thought there was. My bad. So this olfactory pathway from the nose, from that olfactory nerve, it goes to that olfactory bulb. That olfactory bulb is going to follow through this olfactory tract, which is going to synapse in that olfactory cortex in that temporal lobe. And as long as it comes to that cerebral cortex, that temporal lobe is part of that cerebral cortex, that is where we have that conscious awareness of a smell. Olfactory sensations are the only ones to reach the cerebral cortex without going through that hypothalamus. Some axons are going to go to that limbic system because there's certain smells that we have emotional connections to. Maybe it's the smell of chocolate chip cookies. Maybe it's the smell of a loved one's perfume or cologne that signals some sort of emotional response. So it's going to go to the limbic system, but it does not go through the thalamus. So from that olfactory cortex, it's going to go to the orbitofrontal cortex in that frontal lobe. So we know what we are smelling. And we can discriminate it between one smell and another. So people who have damage in this orbitofrontal cortex cannot identify odors. They can smell things, but they don't know what they're smelling. The right hemisphere tends to have greater activity than that left hemisphere for the same area. Women have a better sense of smell than men, especially during ovulation. Smoking will impair your sense of smell, and over time it can cause long-term damage to those sensory neurons. Aging, your sense of smell again will deteriorate. Hyposmia is that reduced ability to smell, and it affects between 65 to 75% of people over the age of 80. Head injury, Alzheimer's, Parkinson's, even certain drugs can lead to a decreased ability to smell. COVID, some people lose their taste of smell. That's anosmia, not being able to smell anything. Taste, gustation. Again, it's a chemical sense because we're putting different chemicals into our mouth. We can only pick up 5 different tastes or chemicals. Salty, because of sodium ions. Sour is hydrogen ions. Bitter, caffeine, morphine, quinine, but it also has like poisonous substances. Some natural responses for bitter is usually to spit it out, and it's more of a protective mechanism for the body. Sweet, glucose, fructose, sucrose, artificial sweeteners such as saccharin, aspartame, sucralose, and umami are those amino acids. So all foods, or most foods, have the combination of these 5 tastes. And then we add thermal sensations in there because we have hot and cold. Odors actually help to play a role in taste. So those odors travel up your nose and stimulates those olfactory neurons because they are more sensitive. Which is why when you have a cold, you can't taste it. Taste is pretty bland. When your nose is blocked, you're not tasting much. So, taste. Those receptors are located in taste buds on your tongue, the back of your mouth. We have about 10,000 taste buds, again, on that tongue, that soft palate, the pharynx, the epiglottis. This is all that tongue and the back of the mouth area. But taste declines with age, just like smell does. So each taste bud we'll have supporting epithelial cells. We'll have gustatory epithelial cells, which are like gustatory hairs that kind of project up. And these gustatory epithelial cells have little taste pores. They only have a lifespan of about 10 days before they are replaced. These gustatory epithelial cells are what synapse with first order neurons that form the first part of that gustatory pathway. Then we have basal epithelial cells. Again, stem cells. And they are going to produce supporting epithelial cells that can develop into epithelial cells, those gustatory epithelial cells. So the different types of taste buds or contours within our tongue. We have lingual papilla. These contain taste buds. They help also to create an increased surface area and a rough texture to the tongue. There's 3 types of these lingual papilla. We have valate or circumvallate papilla, which we have about 100 to 300 of them per papilla. They're in this V shape on the tongue. Fungiform papilla, fungiform mushroom shaped. We have about 5 in each taste bud, and then we have folate papilla. They're in these little small trenches. They're on the lateral sides of the tongue, but most of these tend to degenerate in early childhood. The rest of the tongue has filiform papilla. No taste buds here. They just increase the friction to help move the food around in your mouth to break it down before we swallow. So here's those folate papilla off on the sides. You see these filiform papilla, the fungiform papilla that stand up a little more, and the valate papilla. So most of our tongue is this filiform papilla, but we can see these little things that stick up further, the folate on the sides and that valate or circumvallate towards the back. It shows the lingual tonsil, the palatine tonsil, the epiglottis. This is all further back behind on the tongue. So each of these, this is a valate papilla, circumvallate. You can see as you go down this taste bud, there's all of these taste buds or taste receptors. Each of these here is a taste receptor. So they're only picking up one group of tastes. You can see this fungiform. We'll never get used to that. Fungiform and filiform papilla all along this tongue here. So these tastins. Those tastins are the chemicals that are going to stimulate those gustatory epithelial cells. So we need to dissolve these tastes within the saliva. It has to dissolve before it can come in contact with this gustatory microvilli, which is where that taste transduction takes place. The depolarization of that cell results from exocytosis of these synaptic vesicles from these gustatory epithelial cells that release graded potentials that are eventually going to stimulate these action potentials. So that sodium is going to enter that gustatory epithelial cell. More sodium causes that depolarization that leads to the release of those neurotransmitters. Hydrogen for sour. They're going to enter that gustatory epithelial cell through hydrogen channels, which is going to depolarize and result in release of that neurotransmitter. Sweet, bitter, and umami use those second messengers to cause depolarization of those gustatory cells and release of neurotransmitters. Just like smell can only pick up one specific scent, Gustatory epithelial cells can only respond to one tasting. So receptors for bitter cannot pick up any other. Just like something for sweet or salty cannot pick up any other. So a given taste bud contains these gustatory epithelial cells for each type of tasting, allowing all of the primary tastes to be detected in all parts of the tongue. And again, something that's not just sour is going to stimulate other parts, like chocolate is going to activate a combination. And that combination that gets sent into the brain is what tells you that, hey, this is chocolate. Just like vanilla is going to activate a different combination of gustatory cells to allow the brain to interpret that all of these different signals are coming in saying, hey, this is vanilla. So here's one of these taste pores. You can see these microvilli on top of these taste pores. And then all of these epithelial cells and those basal epithelial cells creating new ones, those gustatory receptor cells that have these neurons coming into it, that is allowing this sending off of this information into the taste center and that insula of the brain. So here we can see this is the tongue. You can see the filiform and the fungiform papilla found throughout here. That is moving things around and helping to pick up different tastes. Here is a microscopic slide of a taste pore that is allowing us, or a taste bud, that it's showing us all the different cells. You can see the little microvilli over here that is allowing that specific sensation of whatever taste this pore is picking up, or taste bud is picking up, to actually detect it. So as I mentioned, this information is actually going into the insula of that cerebellum or the cerebrum. So this information, no matter where it's picked up in the tongue, that specific sensory neuron is going to send that information up into that insula first. So bitter has a very low threshold. Sour is a little bit higher, and salty and sweet are the highest thresholds before these action potentials can be sent out. Just like we can adapt to smell, we can adapt to taste. 1 to 5 minutes of continuous stimulation can actually cause adaptation to occur. So that gustatory pathway, it's, again, the route that information takes. We have 3 cranial nerves that are picking up these specific tastes. Facial nerve is picking up the anterior 2/3 of the tongue. Glossopharyngeal nerve is the posterior third. Vagus nerve is in the throat and the epiglottis. So this information does go through the thalamus, goes through that hypothalamus, and it also goes to the limbic system, because again, there's a lot of different emotions that people sometimes attach to certain tastes. Just like smell, they're going to also do that for specific smells. Taste aversion. Some people may have a taste aversion because taste goes to that hypothalamus and that limbic system. It can create a link between taste and pleasure or unpleasant emotions. So sweet usually evokes this reaction of pleasure, while bitter can give us this gross disgust flavor. Even in newborns, you will see it. So people and animals have this taste aversion where they learn to avoid certain foods that are going to upset their digestive tract. And it was thought to be, and it's kind of, well, it's not thought to be, acts as a survival mechanism. Problem is, people who are going through cancer treatments, at radiation, chemotherapy, it creates a lot of nausea and upset to that digestive canal. No matter what foods are ingested, no matter how much they like those specific foods. So a lot of times they could, like cancer patients especially, can lose their appetite just because everything they eat, they can develop an aversion for just because of the drugs that they are on. Let's look at the ear. So the ear, we have external, middle, and an internal ear. That external ear is the auricle, the external acoustic meatus, and the eardrum. So the auricle makes up the external part that we see. That is that external ear. The external acoustic meatus is that ear canal specifically. It's probably an inch in length, 2.5 centimeters, and it's in that temporal bone, and it kind of leads off to that eardrum. Another name for that eardrum is that tympanic membrane. It's semi-transparent portions between the external acoustic meatus and the middle ear. It's made of epithelial cells. It has connective tissue between the two layers. A perforated eardrum is when that eardrum has torn. Using those Q-tips or cotton swabs to clean your ear. Don't do it. Trauma, middle ear infection. Most of the time it can heal within a month, but there are some people that have a permanent perforated eardrum. So we are able to actually look into the external ear canal. We use what is called an otoscope. This otoscope will let us actually look at the tympanic membrane. It can illuminate, it can magnify the external acoustic meatus and tympanic membrane. We have these ceruminous glands. We mentioned them probably in chapter 4. They secrete that earwax or cerumen. They prevent dust and foreign particles or objects from getting into the ear. They're going to help prevent damage to that ear. And what happens is cerumen tends to dry up and fall out after time. Impacted cerumen is when large amounts of that cerumen become impacted up against that eardrum, specifically that tympanic membrane, and it can actually muffle sounds as it comes in. They usually have to do an irrigation or removal of that wax, and don't do it yourself. Go find a trained medical personnel to do it for you, because it's to be successful and get it done right. Don't try to do it at home. That middle ear. This middle ear is a air-filled cavity or tympanic cavity. It is found within the temporal bone. It is lined with epithelium, and it's going to separate that external ear from that internal ear. We have a vestibular window and a cochlear window found within that middle ear. We also have auditory ossicles that are actually connected by synovial joints. They're named for their shape. The malleus, like a handle, incus, and stapes. These are the 3 bones in order from that tympanic membrane. Incus is the middle, and then that stapes goes to that oval window. The cochlear window found right underneath is is enclosed by a secondary tympanic membrane. So if we come back here, here's that external acoustic meatus, that ear canal here. Here's our tympanic membrane that is separating the external ear from that middle ear. Then we get the malleus, the incus, and the stapes that is attached to that round window. Right underneath that round window, we get that, or oval window, we get that cochlear window, which is that round window. Sorry, the stapes is attached to the oval window. Then we get into the internal ear. But we also have this auditory tube, or eustachian tube as people tend to know it as, that connects that middle ear to like the nose, the mouth area. So this is where people who pop their ears so often, what they're doing is relieving pressure from this ear, this middle ear cavity, which you tend to do when you fly, if you go up really high in an elevator, because of changing pressures. There are two muscles found in that middle ear. Tensor tympani, which is going to attach to those ossicles, and it actually limits movement of those ossicles to try to prevent damage because of loud noises. The other muscle we have is called stapedius. Stapedius attaches to that stapes. And again, it's going to dampen large vibrations of that stapes because of loud noises. Hyperacusia is actually paralysis of that stapes muscle. Abnormally sensitive to hearing. People who are sensitive to loud noises, it only takes seconds for these two muscles, the tensor tympani and the stapedius, to contract. The problem is, in those seconds, they work well for certain things, but they don't work well for other things, like gunshots, a very brief sound. A gunshot goes off before those muscles can contract to protect your hearing. So here's that middle ear again, that malleus, that incus, and that stapes that is attached to this oval window. Here's that cochlear round window underneath with that tympanic membrane again. Stapedius muscle, been cut there, but and here's that tensor tympani muscle. Again, that auditory tube. It connects that that tympanic cavity with the nasopharynx, or that upper throat, lower nasal cavity in the back. So it's normally closed, but swallowing and yawning can open that up to allow equalization of that atmospheric pressure. Popping of your ears equalizes that pressure. So when those pressures are balanced, your tympanic membrane moves freely. If pressure is not equalized, it can cause pain, hearing impairment, ringing in the ears, or vertigo. The thing is this auditory tube, especially in children, it can be a route for pathogens to travel from the nose and throat to the tympanic cavity. Why? This auditory tube in children is more horizontal. So it's more out this way, which allows a lot easier for these pathogens to travel through. As an adult, it's angled a lot more, which makes it a lot harder for pathogens to get in. And this is the most common cause of middle ear infections. So the inner ear, we have a labyrinth and a bony labyrinth and a membranous labyrinth. So the bony labyrinth is in that temporal bone, and it is filled with this fluid known as perilymph. We have semicircular canals, a vestibule, and a cochlea. The membranous part of this labyrinth is endothelial sacs and tubes that contains this endolymph. It has a lot higher potassium levels than that extracellular fluid does. So let's look at this vestibule. This is the oval portion. It contains the utricle saccule and the semicircular canals. We have 3 semicircular canals that are all at 90 degrees from each other. So we have an anterior, a posterior, and a lateral. These all work with equilibrium or balance. There's also an ampulla, which is a swollen portion or an enlargement at the end of each canal. Then we have the vestibulocochlear nerve in that inner ear. The vestibulocochlear nerve are all first order neurons, and they are sending information about vestibulo, which is balance, vestibular. Cochlear is your hearing, and they're going to send information into this vestibular ganglia first. It's the first place it goes. So here's that saccule, that vestibule, that utricle. Here are these 3 semicircular canals. This is all part of your balance. The other side, this cochlea, this cochlear duct, this is the hearing portion. So this vestibulocochlear nerve kind of splits off to a vestibular branch and a cochlear branch. Vestibular is going to take care of that equilibrium balance. Cochlear is going to pick up all that hearing. So on the other side, I mentioned that cochlea looks like a snail shell. But we have cochlear duct, we have a scala vestibuli, scala tympani, and these are all areas that are filled with either perilymph or endolymph. The scala tympani is the perilymph. So does the scala vestibuli. The cochlear duct has the endolymph. And this is where sound is going to travel. The helicotrema, which is the opening of the apex of the cochlea. And this is where all of this information, sound, is going to travel through. So here you can see this cochlear nerve, cochlear branch. We have that scala vestibuli at the top, the scala tympani at the bottom, both contain perilymph. And then we have this cochlear duct in the middle with that endolymph. There's a tectoral membrane and a spiral organ that we're going to go through here. So that vestibular membrane separates the cochlear duct from that scala vestibuli. The basal membrane separates the cochlear duct from the scala tympani. And then our spiral organ, or the organ of Corti. In here, we have hair cells, which are receptors for hearing. We have inner hair cells and outer hair cells, and they work together to pick up different tones of sound. They contain this cilia on top, or sterocilia, these hairs at the top of these cells. And these hairs are going to move. This tectoral membrane is the main thing that moves, as sound waves are going to travel through this cochlear duct. As this tectoral membrane moves, this cilia is going to move. As that cilia moves, it is going to stimulate that cochlear nerve. That is going to send this information into the brain. So I mentioned that tectoral membrane that covers those hair cells. So we hear sounds in waves. High and low pressure regions are going to pick up these different waves. So, frequency of a sound vibration is also known as pitch. So, the higher the frequency of vibration, the higher the pitch. We hear best between 500 and 5,000 hertz. Audible range is between 20 and 20,000 hertz. Speech is between 100 and 3,000 hertz. The larger the intensity of vibration, the louder the sound. Decibels is what we use to measure sound intensity. So an increase in 1 decibel represents a tenfold increase in sound intensity. So the point at which a young adult can extinguish between silence and 1,000 decibels. So rustling leaves is about 15, vacuum cleaner 75, motorcycle or jackhammers around 90. Sound waves start to turn into pain about 140. So loud sounds. Your parents probably yelled at you as a child or teenager to turn that music down. So exposure to loud sounds, any of these can damage those hair cells. Prolonged loud noise exposure can lead to hearing loss. Workers are required to have hearing protectors for anything over 90 decibels now. It didn't used to be that way, but it is now. Rock concerts are about 110 decibels. Have you ever been to one? So deafness is significant or total loss of hearing. So continued exposure to high intensity sounds can cause deafness. The louder the sound, the more rapid the hearing loss. So if you're listening to music through earbuds and somebody sitting next to you can hear your music, their decibels are too loud. The thing is most people don't notice that they've lost hearing until it becomes difficult to understand speech. Earplugs with noise reduction rating of 30 decibels while engaging in different noisy activities can actually protect your hearing. So this goes through the entire physiology of hearing. I'm going to go through the picture. Daha. Starting here. So we hear sound, something, anything. It's coming in waves. These nice waveforms. These waves are causing this tympanic membrane to vibrate back and forth. This vibration back and forth causes this malleus to vibrate, which causes this incus to vibrate, which causes the stapes to vibrate. The stapes, as it vibrates, it pushes on this oval window. As it pushes on this oval window, it's going to go into this cochlea where that causes this vibration to happen of this perilymph. There's different areas within this cochlea that pick up different pitches. So wherever that pitch may be is going to cause that tectoral membrane in this inner ear, in this cochlear duct, to start to vibrate, which stimulates those hair cells. This sound will come back out this other side and come out through this round window. So as this information comes in, sound is going through this cochlea here and being picked up at its specific level where it's then going to come back out that round window. So different frequencies of sound will cause regions of that basal membrane to vibrate. Each segment is tuned to a specific pitch. So the base of the cochlea will pick up high pitch, while the apex of the cochlea will pick up lower pitch sounds. The loudness is determined by the intensity of the sound waves. So high intensity sound will cause larger vibrations. Louder sounds may stimulate a larger number of hair cells. So those inner hair cells are taking those vibrations and converting them to electrical signals that are then being sent off through that vestibulocochlear nerve. So with that basilar membrane starts to vibrate, it causes those hair cells to bend back and forth. and slide up against each other, which is what's allowing potassium into that cytosol. So potassium is very high in that endolymph. So potassium here is going to enter those hair cells, which causes that cell to depolarize. That depolarization is going to cause that action potential, there we go, to be sent off. So when it rests, those hair cells point straight up. Those cation channels are partially open, which allows some potassium to come in, and it kind of causes these weak depolarizing receptor potentials to happen. This weak depolarization can open a few calcium channels, which allows small amounts of calcium into that cell, which will cause some neurotransmitter release. The low level of neurotransmitter generates very low frequency nerve impulses. So this is all causing that depolarization of these cells. So calcium channels open releasing neurotransmitter. That increasing in neurotransmitter generates higher frequency of nerve impulses. Vibration of that basilar membrane causes bending of those hair cells. So as our hair cells are bending one way, while at rest, they're weakly depolarized. A strong depolarizing is going to cause our hair cells to bend one direction. Our hair cells bend back the other direction, it hyperpolarizes. So, depending on which direction our hair cells are going versus at rest, is going to determine whether we're depolarizing, hyperpolarizing, or we're at rest. And what is happening? This is where our cochlea has the ability to produce sounds or otoacoustic emissions. These are inaudible sounds that can be picked up by placing a microphone by the eardrum. And these are vibrations of those outer hair cells that occur in response to sound waves and to signals from efferent neurons, information coming out. They use this to check for hearing defects in newborns. Deaf babies do not produce otoacoustic emissions, or they're a lot smaller. They're greatly reduced in deaf or hard of hearing babies versus a normal baby. So in that auditory pathway, when that neurotransmitter gets released, it depolarizes that first order neuron, which is part of that vestibulocochlear nerve, which is going to go to that cochlear nuclei in the medulla. It'll then travel through this lateral lemniscus to the opposite side and terminate on that inferior colliculus. Other axons are going to go to that superior olivary nucleus in the pons. It's going to send out all of this information. It's going to end up, after traveling through the medial geniculate nucleus, the primary auditory nucleus, it'll go to the auditory association area. First, that auditory cortex and that temporal lobe. Then it goes to that association area of that temporal lobe, so we know what we are hearing. That primary auditory cortex lets us know we're hearing something. That association area lets us know what we are hearing. So that primary auditory cortex, and then that association area is usually that area around that primary auditory cortex. That auditory association area also stores memories and compares present and past auditory experiences, allowing you to recognize particular sounds. Lets you know you're hearing speech, music, noise. So if sound if the sound is speech that you're hearing, it's going to go to that Wernicke's area so you can understand what you are hearing. Equilibrium, or your balance. It is that body's movement that stimulates receptors such as acceleration or deceleration, tilting your head, and rotary movements. So we have that vestibular apparatus, which is for equilibrium, which is that utricle, that saccule, and those semicircular canals. We have otolithic organs, which are known as that utricle and the saccule, and then we have the macula. That macula does linear acceleration or deceleration and head tilt. So linear, speeding up in a car, slowing down. That macula lets you know that's happening. So we also have hair cells here. These hair cells have that same sterocilia, and they are of different height. And then, of course, we're going to have supporting cells. We have an otolithic membrane with otoliths. Have you ever heard of somebody saying the stones in their ears? Those are otoliths. So that utricle and that saccule are perpendicular to each other. So when the head is upright, that macula of that utricle is horizontal, and that macula of the saccule is vertical. So that utricle responds to linear acceleration or deceleration. So when that head tilts forwards or backwards, when you're moving in a car, forwards or slowing down, that saccule is linear acceleration and deceleration that occurs in a vertical direction. So riding up and down in an elevator. If you tilt your head forward, those otolithic membrane and otoliths are pulled with gravity downhill and moves those hair cells. And if you bend your head back, they go the opposite direction. So going one direction is going to polarize or depolarize. Going the other direction again will hyperpolarize. So we have this otolithic membrane here with these stones. And as you move your head these different directions, that force of gravity is pulling everything forwards. Versus when your head is straight up, everything is balanced. So as your hair cells depolarize and hyperpolarize, they're releasing neurotransmitters at different rates. And again, this is going on that vestibulocochlear nerve. These neurons that are sending off this information they're synapsing with these first order neurons, or these sensory neurons that are taking this information in. The semicircular canals or ducts, they lie within those three separate planes, that anterior, that posterior, and that lateral. The positioning of these is for rotational acceleration and deceleration. So that ampulla, which is the enlargement at the end of that semicircular canal, has this small elevation at it, and there's hair cells and supporting cells there again. So when your head rotates, those semicircular canals, ducts, and those hair cells move. So here's that ampulla with that cupula, that large amount of material here. So when you're rotating your head side to side, it's detecting that you're turning your head to the right versus turning your head to the left. So that endolymph, it's technically not attached, so it kind of drags behind with inertia. It's kind of interesting how that works. So the drag of that endolymph allows those hair cells to eventually bend, and you know that you're turning your head to the right or the left. So if the head continues to move at a steady pace, that endolymph begins to move at the same rate, such as you spin in circles in one direction and you continue to spin in that same direction, like on a carnival ride or something that spins in circles a lot. So once the head stops moving, that endolymph temporarily keeps moving because of that inertia. It'll eventually stop and come back to its resting position, but it takes a little bit for it to get there. So that rotating of that head allows that entire copula to move in that one direction and depolarize, and it continues to go in that one direction after your head stops for a short period of time. So our equilibrium pathway, that'll helps us with that balance and everything. We have that vestibular ganglia, the vestibular branch of the vestibulocochlear nerve that goes through that vestibular nuclei. It's going to go through those inferior cerebellar peduncles. That vestibular nuclei integrates that information from that vestibular, visual, and somatic receptors. So what your body's feeling, what you're seeing, and where your body is in space, all of that information is coming in to this vestibular area in the parietal lobe. And it allows you that conscious awareness of position and movement of your head and limbs. So all of this information from this all areas, visual, where your body is in space, and that proprioceptive, that is, and that vestibular is all coming in to allow you to know where you are in space and allow your body to adjust accordingly. So motion sickness. Motion sickness has to do with what your ears are feeling, what your eyes are seeing, and what your joints are feeling are different. So, say you're on a moving ship. That ship is moving up and down. Your ears are feeling it, but your eyes do not see it. They don't see that movement. So there's that conflict between the two, and that's what causes that motion sickness. People who get car sickness, people who may get that motion sickness in an airplane, I experienced it for the first time when I traveled overseas for the first time. Domestic travel, it doesn't bother me, but as soon as I leave the country, it did. So you get this paleness, restlessness, excessive salivation, nausea, dizziness, cold sweats, headache, malaise, and possibly into vomiting. Dramamine works wonders. They have non-drowsy Dramamine out there now. The regular Dramamine will put you to sleep, but it helps to kind of, what it does is it relieves the symptoms. It does not fix what your eyes are seeing and your ears are feeling being different. People who get car sickness, that's why they say to look out the window, sit in the front seat, look out the window when you're in the car. So that way your eyes can see what your ears are feeling and to prevent that car sickness from happening. So this all goes through all of the different structures of the ear. Let's look at the eyes and the ears. They start developing at 22 days after fertilization from that ectoderm. The eyes start as the optic grooves that are eventually, they're going to form these optic vesicles, which will form these lens placodes, these optic cusps, these lens vesicles. So here we can see those optic grooves, which are coming into these optic vesicles. These lens placodes are starting to form. There's that lens vesicle coming back and in, this choroid fissure, this optic cup. These are all coming in by about day 32. Those ears, as I mentioned, are also at day 22. We get these otic placodes to these otic pits, these otic vesicles, the pharyngeal pouches are coming in, which is giving us these pharyngeal grooves. So here you see this otic placode starting on the side of what will be the head. Then it becomes this otic pit, which becomes this otic vesicle by about 32 days in. So let's look at aging. So most people don't experience problems with their taste and smell until about 50 years old. And it's this gradual loss of olfactory sensory neurons, gustatory receptors, and they just replace slower as we get older. So our eyes, that lens is going to lose some of its elasticity, so it can't change shape to focus. Presbyopia. Cataracts is when that lens becomes cloudy. The sclera, which is the whites of the eyes, can become thick and rigid. They can eventually become yellow and brownish. And that's from the light, wind, and dust. They can also develop these random splotches of pigments. That iris will fade or get some irregular color to it. The muscles that regulate your pupil will weaken. So responding to that bright light, when somebody shines a light in your eye, or even when you're driving in the lights, they have a harder time like adjusting to bright lights. So there's different retinal diseases like macular degeneration or detached retina, glaucoma, too much aqueous humor in the front of that eye, tear production decreases, and it can cause dry eye. Those eyelids will lose elasticity and become baggy and wrinkled. The amount of fat around your eye will eventually decrease and your eyeballs can sink in. Your sharpness of vision will decrease, color and depth perception are reduced. You can get these little vitreous floaters. Family Guy. There's an entire episode about vitreal floaters and all those little things that he kind of sees floating around in his eye. Kind of funny. So by the age of 60, 25% of people will notice hearing loss, especially to those higher pitches, presbycusis. Be loss in hair cells or degeneration of that nerve pathway. A lot more people experience tinnitus, ringing in their ears. Vestibular imbalance is more common as we get older. So we mentioned cataracts. Cataracts is that loss in transparency of the lens, and it causes blindness. That lens becomes cloudy because of a change in the structure of the lens proteins. You can have excessive ultraviolet rays. Certain medications like long-term steroids can cause it. Complications of diabetes or other diseases. Smoking. Smoking causes just about anything in the body, just like diabetes can. And then they can put in an artificial lens, which can restore sight for people with cataracts. It is something that can happen. Glaucoma. This is the leading cause of blindness in the US, and it is high intraocular pressure because of a buildup of that aqueous humor, which is the fluid in the front portion of the eye. That fluid is going to compress that lens into the vitreous humor in the back of the eye, so it starts putting pressure on the neurons of the retina. That constant pressure is going to start to cause visual impairment. It's usually painless. The other eye can usually compensate for a while, so they don't necessarily notice until the damage has become too extensive. African Americans are more susceptible. Just increasing age is unfortunately a risk factor. Family history, eye injuries or disorders. We also have normal tension glaucoma. This is damage to the optic nerve with loss of vision, but it does not have to do with that intraocular pressure. It's usually because of a fragile optic nerve, so vasospasm of the blood vessels that are near that optic nerve, which causes a loss of blood supply. Loss of blood supply means they're not getting the nutrients, so those cells aren't going to work. Deafness, hearing loss, sensory neural deafness has to do with the hair cells in the cochlea or that cochlear branch of the vestibulocochlear nerve. Atherosclerosis, which can reduce blood supply to the ear. Repeated loud sounds are going to destroy those hair cells. Drugs like aspirin or streptomycin, genetic. The other type of deafness is conduction deafness. It has impairment of the external and middle ear mechanisms. So, otosclerosis, deposition of new bone around that oval window, impacted cerumen, injury to the eardrum, and just aging. That's thickening of that eardrum, stiffness of the joints of those auditory ossicles. Those are all going to play a role in this. How do we determine hearing loss? Well, there's this test. There's this test called Weber's, and it can actually distinguish between sensory neural and conduction deafness. We use a tuning fork. It is held at the forehead, like in the middle between both ears. So if hearing is best in that affected ear, it's conduction. If sound is heard best in the normal ear, it's sensory neural. So Meniere's disease, increased endolymph, which causes that membranous labyrinth to enlarge. Fluctuating hearing loss, roaring tinnitus, spinning, or vertigo. You kind of get this destruction of hearing that's going to end up occurring over the years. And then I mentioned that middle ear infection, otitis media. And it's because of bacteria. It's usually associated with an infection in the nose or the throat. So pain, malaise, fever, reddening, and outward bulging of the eardrum. It can cause it to rupture if it's not treated. So bacteria tend to go through that auditory tube of the nasopharynx from that nasal cavity up into that middle ear. As I said, children are more susceptible because their auditory tubes are almost horizontal. And there's tympanotomy. It's frequent otitis media. So they're constantly having those middle ear infections. And what they do to treat that is they put tubes into that eardrum to help kind of relieve some of that pressure in that area. Well, that is everything on this chapter of hearing. Thank you very much for listening and have a wonderful rest of your day.